Hello and welcome back to another episode of the Oncology Brothers podcast. I'm Rahul Gosain, here as always with my co-host and brother Rohit Gosain, with a focus on keeping our fellow community oncologists up to date in all that is happening in the world of cancer. Today we're diving into GU ASCO 2025 conference highlights with Dr. Toni Choueiri, a world-renowned GU medical oncologist from Dana-Farber Cancer Institute. Toni, thanks for joining us.
Well, thank you so much. It's always a pleasure to talk to you and discuss the latest in GU oncology.
Thanks for joining us, Toni. We've got a lot to unpack here. We'll start off with the TALAPRO-2 study from prostate cancer world, and then we'll dive into the bladder cancer space, discussing NIAGARA update, and then closing off with renal cell carcinoma with CheckMate-9ER update, and then, of course, since we have you here, TiNivo-2 update as well. Okay, focusing on our first study, which is TALAPRO-2 study presented by Dr. Neeraj Agarwal. The study got a lot of attention, mainly with regards to the role of PARP inhibitors. We know that there is quite a bit of role in BRCA or HRR mutated patients, but again, with all comers, this was certainly a hot topic. Toni, could you please touch on this study design and its findings?
Yeah, TALAPRO-2 is a study that Niraj presented really well. It has more than one cohort, but the patient characteristic, it's the first-line castration-resistant prostate cancer. And with the emergence of castration-sensitive, we need to make the distinction. Patient with good performance status get randomized to enzalutamide, sometimes not my first choice after progression on abiraterone, but we don't have a lot of drugs to work with, or enza plus placebo, or enza plus the PARP inhibitor talazoparib, which we call TALA. Enza is the full dose, 160 milligram once a day monotherapy, and talazoparib 0.5 milligram. So we know now for 10 plus years that these drugs work best in patients that have HR gene alterations. The hallmark there, this is a category that include many genes, including BRCA1, BRCA2, PALP2, ATM, and other. But in my opinion, the one that are most common and most important are BRCA2 and BRCA1. And what they did here is that you could have a tissue test from this tissue cancer or a liquid biopsy test as interchangeable. We can discuss that. There is data from Dr. Neeraj Agarwal himself and other that they're complementary. You can miss some by tissue that the biopsy picks up and vice versa. On the other hand, I would argue that you missed it because it's a selection bias more than anything else. If you repeat the tissue 5 times compared to 1 time, you'll have more. If you repeat the blood 10 times compared to more, you have more. But yes, both are okay. So 800 patient study randomized both, and the stratification is by prior ABI or docetaxel in the castration sensitive, which makes sense because all these patients were castration sensitive in the past, and the HR status, gene alteration. Primary endpoint was radiographic progression-free survival. A key secondary endpoint was overall survival, prostate cancer, other endpoints. So the primary endpoint of progression-free survival, I believe this was presented before, and now OS, and OS was significant. Remember, OS was in all comers. If you want to say this was significant, 20%, 21% risk decrease in the risk of death. It was significant. 8 months difference, 45 versus 37. You have to stratify. You have to look at the one that has HRR. The majority of the benefit was in that population. The first data cut, I believe, August 16, then September 3, they were all, significant. But going to the in HRR positive, the data was significant. It was strong. When you look at the one that are HRR negative, actually there is a trend. There is a trend, but it's not significant. I would love to see the confidence interval not cross 1. But I was surprised. I thought that there will be no effect at all whatsoever, and this was not true. So the question here, you asked me directly, I'm a straight shooter. Will I do it, everyone? Absolutely not. But if there's a young guy that comes in, liver metastases, can tolerate treatment, want everything under the sun, could I deny him TALAPRO because of this OS trend in HRR negative? I don't know. That's a discussion. It's a shared decision. I may give it Let's put it that way. Because in HRR negative, I would say there's a trend. My first thing will be no, I only do it in positive patients.
Yeah, a few things to unpack here. The TALAPRO study looking at OS, but Rohit, you started off with this. Toni, you're bringing the same point. Majority of this benefit is driven through HR mutated disease. And I think it's important to keep that PARP inhibitors are not benign. We have to worry about anemia, neutropenia, MDS, and fatigue. So whenever we're bringing something like this, shared decision, but we also have to keep the side effects and what's the benefit in all comers.
Well, keeping these side effects is extremely important, as PARP inhibitors not just get utilized here, whether that's prostate cancer, but also for breast cancer, pancreatic cancer, and ovarian cancer. As a result, getting comfortable with these side effects is extremely critical.
Yeah, coming back to TALAPRO, I think the biggest take-home message here is the importance of testing germline and somatic mutation. That is very important.
Right. Now, diving into bladder cancer world, let's talk about NIAGARA study update here. The current standard of care in bladder cancer for localized or locally advanced is if one is cystectomy eligible, one should see if the patient can receive cisplatin therapy. If they have received neoadjuvant chemotherapy with cisplatin, and if there is residual disease, for that high-risk patient population, we have approval of adjuvant nivolumab. What we saw here was from ESMO 2024 was peri-op approach with Durvalumab, presented by Dr. Tom Powles, part of NIAGARA study. Given these exciting initial results, though not FDA approved, some of us have started using this as a standard of care approach if insurance approves it. Toni, can you touch on the study design and the recent updates?
Yes, Dr. Powers continues to change the standard of care. I think if you change it one time in your life, you get probably the biggest prize on earth for clinician, but on every meeting change it. So great study. GemCis is a standard, GemCis or dose-dense MVAC in neoadjuvant in cisplatin eligible versus the PD-L1 inhibitor Durvalumab, where GemCis is compared to GemCis Durva before radical cystectomy. Now, the interesting thing I have to say here, in the Durva arm, you will get a 8 cycle of adjuvant Durva. I don't like that. Okay, if I have to design this again, which I don't have any right to do, and if I have a couple of 100 million, which I don't, I will add the third arm that is neoadjuvant only with Durva GemCis without adjuvant Durva, because you may not need it. The investigator here and the sponsor decided you will. So maybe patients are happy. I would like to see both. But beside the point, T2, T4, as long as they have urothelial cancer or urothelial cancer plus something else, not small cell, creatinine clearance, they went to 40. I'm very proud of this because a lot of us, Guru Sampavdi was at the Farber, he did that for a long time. But a lot of us are pushing for cisplatin, not if your EGFR is 60, but we can go down to 40. I don't know if this study allowed you to split, but we give a lot of fluid. We watch the patient closely, and we're noticing if your EGFR is 45, 50, we are getting away with cisplatin.
You brought up this is going to be practice changing. Walk me through the study findings, Toni. What do we see here?
We saw the primary endpoint, pathologic CR and event-free survival. This is published in the New England Journal of Medicine. It's not, you're right, it's not approved. I believe this should be approved. I changed my practice. If a young patient can get cisplatin, I would say 2 out of 3 or 3 out of 4 patients, I'm able to get Durvalumab for them. I don't do Pembro chemo because I have to follow the data. Matt Gelsky presented an update and looked at event-free survival based on pathologic CR. Some patient had pathologic CR. We can have pathologic CR with chemo only. This was more about pathologic CR on histology than about NIAGARA. If you achieve pathologic CR, you can be happy. 86% event-free survival versus 92%. So yes, 6% more. Achieve pathologic CR in someone with muscle-invasive bladder cancer, you can tell them they're going to be fine. You are almost 90% sure you're going to be fine. Give them a hug and send them home. You need to follow them. But that is impressive. If it's not pathologic CR, even if you downgrade, I would love Matt to have shown pathologic downstaging to non-muscle invasive. I bet it will be in the middle. But he lumped the non-pathologic CR altogether. Well, guess what? That's not great. Their event-free survival is around 50%, less than 10%, but better with adding Durvalumab. So he shows here, I think it's more about being pathologic CR. Of course, the median event-free survival, 58 and 0.77, they're both statistically significant and favor Durva. Yes, they do. They do both favor Durva, but I like this message to be that pathologic CR is great, whether you get Durva or not today. But it's statistically significant. Look at these confidence interval, 0.999, 0.948. But, it's there.
Right. Yep. And again, out in the community, yes, we're waiting on FDA approval for this, but many of us are doing this now in our clinical practice. This is very similar to what we've seen with triple negative breast cancer, lung cancer, and actually this study, NIAGARA, did not have that third arm, Toni, that you mentioned. So we don't know how much that adjuvant immunotherapy is adding. Very recently, we saw an overall survival benefit as a press release for lung cancer just from CheckMate-9ER, just saying that maybe the neoadjuvant chemoimmunotherapy is good enough. More to come on that. All right, switching gears to RCC, now to CheckMate-9ER, looking at Cabozantinib with Nivolumab, which was approved back in 2021 in first-line metastatic RCC. Toni, we have a few options, including dual checkpoint inhibitors with other TKI with immunotherapy combination and also single-agent TKI. Your thoughts on this update for CheckMate-9ER, and then let's also talk about what next if the disease was to progress.
I think this study that we ran was many folks, Bernard, Tom, my co-chair was Bob, and Bob presented the study. That was the last update done of Nivo-Cabo versus Sunitinib in all the standard, and with 67 months median follow-up, all the primary endpoint, the triple endpoint of response rate, PFS, and OS were met. The progression-free survival is double, 8.3, 16.4. The hazard ratio stayed the same. But the OS, we were afraid it will be lost. Luckily, 11 months difference, 21% decrease in the risk of death with the combo of Nivo-Cabo. Cabo at 40 milligram once a day versus Sunitinib. I'm happy this persisted. I would love to have seen the curve flatten like with Nivo-Ipi. Maybe it didn't, maybe it did at 72 months, but remember, that's after the follow-up. There's a lot of censoring around that time, but no doubt, this beats Sunitinib every day. And the Nivo-Cabo is one of the first-line options used in the community, used in academia, used all over the world when there is available drug.
And again, this just reaffirms the fact that we have dual checkpoint inhibitors in metastatic space or immunotherapy with TKIs. And of course, we still have TKIs. And beyond first line, Toni, how are you going about this space? Especially this is something that you covered with TiNivo-2 study. And since we have you here, if you don't mind touching on the study design here and important findings, what we saw at GU ASCO 2025 was also patient-reported outcomes. Your thoughts here, sir?
It was Brad McGregor and Katie Beckerman that led both studies. So what we did, we've seen a lot of folks in the community or in academia saying that you should always keep the PD-1 on board. Let's keep the Nivo, let's keep the Pembro and circle. Is there a rationale preclinical for it? I'm sure I can find something. But is there any rationale to keep the antibody on like some people keep bevacizumab, Herceptin, especially with the long half-life, etc. So we designed 2 studies only in renal cell that informed the majority of solid tumor. Now, there is a small exception in a small randomized phase 2 in melanoma, which showed no OS, but the PFS benefit to rechallenge. But here, this is the second study after Contact 3, where we use the PD-1 inhibitor Nivolumab to rechallenge, and the backbone is Tivozanib. Knowing in the combo the Tivozanib dose is lower, and Tivozanib and the TKI intensity is important in renal cell. I don't think that's the reason the study was negative. So in patients with metastatic RCC that experience disease progression up to 2 lines of therapy, one of them is a PD-1, PD-L1 inhibitor. They get Nivo is the experimental here. Primary endpoint PFS, all the endpoint. everything was negative. We published this in the Lancet. It was a concomitant publication, totally negative. What was done here is the quality of life gave us an idea in some group analysis. I don't think they led to picking a population, a subpopulation that benefit from the combo. That's the message. Brad McGregor did very good analysis on tivozanib dosage across most of the studies. So this was very good.
Yeah, and again, throughout different disease sites, be it lung cancer, be it melanoma, and a lot of these studies have moved immunotherapy up and upper. We saw that with NIAGARA as well. So a lot of our patients are getting exposed to
Right.
immunotherapy with
So
early
what do you
disease.
do? This
Exactly.
is different.
Yep,
This is
absolutely.
patient that experience disease progression while they're
While
on the immune checkpoint. If you have a CR and you're free of disease, free of treatment for 2 years, and you re-challenge, that's different. If you
Absolutely.
have side effects after 2 doses and don't do any more immune checkpoint, you go to chemo, to a different, and then an immune checkpoint that is safe comes in, you want to re-challenge, that's different.
Absolutely.
Now, the interesting thing I have to say, it's a small subgroup. 1/3 of patient guys had a therapy in the middle. On contact 3, the last therapy was a PD-1, PD-L1. Here, third of a patient got a TKI in the middle. The PD-1 was within 6 months, but they got a TKI. So imagine, you progress on Pembro-Axi, you get Cabo, you stay on Cabo 4 months, you experience progression, then you can go on the study because your Pembro was within 6 months. I believe it was 6 months.
Yep. Yep. And again, Tony, with so much happening in this space before I close, how are you positioning tivozanib and belzutifan at the time of progressive disease?
When you compare, you don't have them head to head, but interesting
Yeah.
enough, when you look at similar, they have similar PFS, but the response rate is higher with Bell. And like you said, many of these drugs, this was an attempt also to move Tivo earlier, right? Second line. And it gave you a great data with Tivo as second line post IO. It was over 9 months. And when you look at Bell's second line, it's a small subgroup in LightSpark 005. It's also good. So all these drugs are moving earlier line, and Bell in specifically is moving second line. We finished that study. First line, that's LightSpark 12, adjuvant. So
Yep.
I think, in a way, if you ask me that question, it will be hard to answer. The response rate, maybe the tolerability is better with Bell, but the PFS same. We can play around more with Tivo. We know how to manage Tivo. It's been older drug. I see some patient with a lot of lung issues. I'll be honest with you. A lot of them are anemic. Now, anemia we can manage. Lung issue, JCO, COPD, etc. You have to be careful. What I do is I sequence them. You can have responses to Bell in patient exposed with Tivo. So the idea is I'm shifting the question, say they should be used sequentially. Which one? I don't know.
Absolutely.
Luckily, I have this patient actually recently where I picked Bell over Tivo. Unbelievable side effects to all TKI, and the blood pressure shoots from 120 to 190 no matter what. But I want to avoid all TKI no matter what. They get Bell. I have another patient that's COPD on intermittent oxygen at night. Probably doesn't need it, but at night made him feel better. It's like, oh, that's an easy decision. Could I have done Bell full dose and watch the? Actually, I did Tivo, but next time, if they progress, they just started a few weeks ago. I'm gonna watch full dose and watch the saturation very closely. So that's more option to patient. That's probably why patients are living longer with their disease.
These two studies continue to show that these agents are active after immunotherapy.
They're active, actually, many of the drugs, if used them earlier. But since we don't have a biomarker, we don't know which one we want to use earlier.
Absolutely.
So you end up sequencing the rule.
Yep. Again, we've covered a lot here in the last few minutes, from prostate cancer to bladder cancer, and then closing off with RCC. Toni, as always, thank you so much for taking the time to go over these key studies from GU ASCO 2025. For our listeners, before we close, let's do a quick recap. In today's episode with Dr. Toni Choueiri from Dana-Farber, we've covered key studies from GU ASCO 2025. Starting off with TALAPRO-2, where we saw talazoparib improved overall survival in all comers. This study reinforces the importance of germline testing and NGS testing in prostate cancer.
Yes, we can never undermine the importance of NGS testing in the era of personalized medicine. With regards to the PARP inhibitors, as a general medical oncologist, we have used this across multiple cancers, whether that's breast cancer, pancreatic cancer, and in fact, ovarian cancer. We do need to get comfortable in managing some of these side effects with these agents. We also had a chance to touch on the new standard of care in resectable muscle-invasive bladder cancer, the NIAGARA trial update. We are eagerly awaiting FDA approval for this regimen.
And to close, Rohit, we also had a chance to talk about the recent update from CheckMate-9ER for Cabozantinib with Nivolumab in first-line RCC. Dr. Choueiri walked us through second-line and beyond in RCC for TiNivo-2, role of tivozanib, our available options, including belzutifan. There's a lot that we've covered here. We hope that you enjoyed this episode. If you feel that these conversations are helping you, please share this episode with a friend or colleague who might also enjoy this. Leaving us a review helps us increase our visibility and expand our reach, helping more oncologists provide the best care close to home. Make sure to check out our other discussions, including treatment algorithm series from breast cancer, FDA new approvals, and these conference highlights. Thanks for joining us. We are the Oncology Brothers.